Hi, everybody. I'm here with someone I'm pretty sure many of you are going to recognize, Dr. Eric Hardt, a medical oncology specialist from Boston, Massachusetts, with over 48 years of experience in the medical field. He graduated from Tufts University School of Medicine in '74 and is affiliated with Boston Medical Center. Although he's currently retired, Dr. Eric Hardt was recently awarded the Tony Windsor Award at the 2021 Massachusetts Area Health Education Center's Paving the Way to Healthcare Access Conference. Congratulations. Eric was also Tony Windsor's longtime partner in crime in language access work. At Tony's request, Eric conducted research on the cost and value of medical interpreters, and together they used this research to pass Massachusetts' first bill requiring medical interpreters in emergency rooms and psychiatric units. Although Eric is not an interpreter, he's an MD and a monolingual one at that. But his advocacy and training for medical interpreters has always been the most important aspect of his academic, political, and intellectual work, at least since 1985. Eric is the author of critical research, some of the first of its kind, showing the financial costs and clinical consequences of language barriers and demonstrating the difference in error rate between ad hoc and professional interpreters. Eric used his position to give recognition and credibility to the medical interpreting field, which was instrumental to the passage of state laws, institution-level policies, and culture change. Without his contributions, relentless over decades, many more LEP patients would still be relying on their children or the receptionist or the cleaning lady to get interpretation services today. So thank you so much, Eric, for always being present at our conferences, for advocating for the profession. And we're here today to get some insights from you as to what NCIHC was like at the beginning. So let me ask you, can you speak about a couple of items, 2 or 3, that propelled you on this path towards linguistic equities? I mean, you graduated from Tufts, you say you're monolingual. How did this come to be, this passion for advocating for healthcare interpreters?
Now, I should put myself on a timer. And remember, when you're talking to an old man, you're going to hear a lot of stories, quote, from the old days. And that's what I have fun with. So we'll start there. Now, when I was in like 2nd and 3rd grade, I spent a lot of time at my grandmother's house. She was an Italian-born immigrant, diabetic, illiterate, speaking the Calabrian dialect of Italian, which I learned to understand a bit because I hung out with her and her friends a lot. I did translation work for her when she sent stuff to Italy. And when her doctor came over to make a home visit for her diabetes, my cousin came down from upstairs to translate, back in the day when they didn't know the right word for that, for my father. And I knew enough Italian to realize Nana was saying that her needle was hurting her so much when I helped her get the shot that, maybe she needed a new one. And when she said this, Jerry, that's my cousin, said to my father, who was the doctor, she's fine. Everything is okay. She doesn't need anything new. I got to go upstairs. I'm cooking and my kids are up there. To which I said, wait a minute, Jerry, that's not what she said. To which she said, Eric, shut up, go to your room. And I went to my room and I realized I never forgot that the person I love the most on this planet was not able to tell her doctor what was wrong. And her doctor, who was my father, couldn't hear what her problem was in order to help her with this. Just a new needle would have done it. Now, I studied, I was a Latin psych translator in high school and studied ancient Greek and modern French, but I was never, language access was never on my political agenda. A lot of other things were on my political agenda, even through medical school, because it was never mentioned in medical school between 1970 and 74. After training at Tufts, I went to New York City for 10 years. I basically worked for the city and universities. I worked at Harlem Hospital full-time for 10 years, and then moved up to Jacobi Hospital in the Bronx full-time for 5 years while still being part-time at Harlem. And what I noticed at Harlem, well, first of all, most of our doctors and nurses and staff were Black. Most of our patients were Black. So I learned a lot about culture and politics there every single day that I worked at Harlem Hospital. And I will always be indebted to my colleagues then. And like all of the doctors, we competed like crazy with each other. Each one of us wanted to do the best possible job on every single patient. And anybody who had something that they didn't know, the colleagues would come up with the answer and let them know how to figure out that answer next time. So we were totally committed to this underserved community, every one of us, except when we didn't speak a patient's language. And it was only occasionally we had a patient who spoke Spanish. And I don't even think we knew the difference between Puerto Rico and the Dominican Republic in those days. And we didn't know what to do. We had all learned a poquito de español, donde es dolor. And we tended to like drift into what I called veterinary practice, where, you know, you push on the belly and say, dolor aquí, dolor a la cabeza. It was the silliest history taking you could imagine. Or if we knew somebody who spoke Spanish, like it was another doctor, we would basically switch and let that doctor take care of that Spanish speaking patient. Or if there was a nurse on the other floor that spoke Spanish, she would come down to serve as the translator for us. But we always knew that we were not doing our best job. We weren't getting all the information. The patients weren't always understanding what we thought about the situation, what we thought they should do. Mm-hmm. And the chart always said, quote, history unobtainable, secondary to language barrier, which meant, I'm sorry. I tried to do my best, but I can't if the patient doesn't speak my language, meaning that I don't speak the patient's language very well. And that was true for 5 years at Harlem Hospital. Then when I went to Jacobi in the Bronx, language diversity was much increased. We had Chinese speakers and Polish speakers and a variety of other languages, Vietnamese. And there was a retired physician who had put together a program for interpreters. Basically, what he did was he got full-time hospital workers from the kitchen, cleanup workers, secretaries and whatnot, who knew another language and who would volunteer to be an interpreter if a doctor needed one. So literally, you'd go into the room and pick up a chart and discover that somebody spoke a certain language. And then you would go to the secretary and then you would hear an overhead page. Will the Polish interpreter please come to the primary care clinic? Polish interpreter to the primary care clinic. And if they didn't show up, we would go out to the waiting room and say, does anyone here speak Polish? And if they did, we'd bring them into the room. And I realized that that was better than what we had at Harlem Hospital. We had another human being who spoke 2 languages in the room. The person who got called didn't know. I remember specifically having a Chinese interpreter show up for a Vietnamese patient.
Ouch.
And they laughed at each other, realizing that they were being confused. But I realized that it was better having another person in there, even though they knew nothing about medical terminology. But there was a little bit of relationship building between what was often a couple of immigrants and usually women, at least 90% of the time. So it kind of occurred to me, gee, maybe there's a way out of that history unobtainable secondary to language barrier. And then I fell in love with a woman and followed her to Boston, did whatever she told me to do, and called up Boston City Hospital and told them that would be the only hospital in Boston I'd want to work at, got hired at a low salary. And then when I started working there, I realized, wow, we have patients who speak something called Cape Verdean, Somali, Vietnamese, Spanish, God, all these languages. And there was some diversity of the staff, but not enough to cover that. And I was sort of scratching my head. What are we supposed to do? You know, we're still not doing as good a job as we want to do for these, again, underserved communities going to Boston City Hospital. That was in 1984 when I showed up. And then in 1985, this woman got hired to be the nation's first full-time director of interpreter services. Her name was Raquel Cashman. And Raquel she had heard that had been making a fuss about issues like language access, although I didn't have that phrase yet. So she set up a meeting with the two of us, and I just, that was it. I became her buddy for the rest of her career. She told me that when she went to high-level meetings with administrators, usually doctors, trying to convince them that she needed an expanded budget, more interpreters, new languages or whatnot, that they would look at each other and say, very good ideas. You're certainly committed to the community. Okay, next, who's next on the agenda? And then I told her, I tell you what, give me a title, capital letters, medical consultant to interpreter services. You don't have to pay me anything. And let's take interpreter services on the administrative diagram. Instead of putting it under nursing, we'll make the point that actually it serves nursing, MDs, physical therapy, social work, dietitians. So it should go up the administrative ladder with a medical consultant to interpreter services, just a doctor who doesn't know any languages, who's not an immigrant. And basically, for the next, that was what was enthused. Raquel and I started keeping data and statistics. We would get her budget. We would divide it by the number of contacts. She was literally drawing, table charts and circular charts, which I showed her how to draw with the help of a glass, making a circle. And then we would figure out what the average cost of our encounter was, which was one year, $17.50. So we would go, and that made a difference somewhat. So we were keeping track of that. We came up with this idea: interpreters were only being used for outpatients because, quote, administration said they didn't really need it for the inpatients because there were nurses around and other workers who spoke these languages. We could always just bring them over. And Raquel and I very quickly said, that is stupid. No, I forget what our term used, but we made the case that we needed professional interpreters trained in how to be an interpreter, trained with what these healthcare providers are trying to figure out and what they're trying to explain to the patients. Unlike the worker from the kitchen, usually would not know, no matter how wonderful they were. And so we made progress after progress. And I have to say, I just felt like I was one of Raquel's students. I was a full-time clinician. My full-time job was taking care of patients and teaching students and whatnot in medicine. But then when I had, in my, quote, spare time, I would follow Raquel around. And every time she set up a meeting, and I discovered, well, we always in those days thought Boston City was the greatest hospital in Boston. And that all of these other Harvard hospitals, Mass General and the Brigham and whatnot, that they were trying to compete with us. So when Raquel Cashman established what professional interpreters could do, they started hiring people and developing interpreter services department. And Raquel would set up meetings with all of them, and I would be asked to attend, and I would suggest that each one of them find a doctor or a nurse who's monolingual like me to be an advocate for them at their hospital. And that's why I was there when the MMIA was founded, because of Raquel's invitation. So I was really there to learn about what interpreters did, how they did it, what they needed to know. And then in the beginning, I was just teaching that to medical students, but also to national nursing organizations and all the other medical organizations that I was part of, whether it was the National Public Health Organization, oncologists, home care, geriatrics. I would go to all these annual meetings, and my workshops or talks would be about working across language differences, which had never been seen anywhere. So that's how I got. We'll talk about NCIHC in a minute, but I have to back up to 1985. I thought I was the only doctor who cared at all about this language stuff until one day, picked up my copy of the New England Journal of Medicine, and there the lead article was by a guy I'd never heard of named Dr. Robert Putsch. And it was about the importance of dealing with language differences in healthcare. And it was like, I felt like he was talking to me directly from Seattle. And it was like, wow, you mean there's another guy who cares about this? I got to meet him. And one of the good things about Raquel and the MMIA was that we started having meetings. Well, you know, it's an East Coast, West Coast competition thing. It's like Yankees and Dodgers, or now, God forbid, the Yankees, Red Sox and Dodgers. And we thought that the West Coast was trying to compete with us to get statewide organizations and even, God only knows, a national organization. So I would get invited to meetings out in Seattle, meet Robert Putsch, and other meetings in Canada, and Florida, and Texas, and California. And I saw the profession expand with departments of interpreter services around the country, including even Nebraska. I went to give a talk. The country, the state
and
that my
I just
father
want to
came
say for the
Yeah.
listeners, folks, just to put this in context, everyone who was struggling against the same challenges in overcoming the barriers that are present with cultural and language differences were doing so in their own little space, feeling like they were very alone. And this was before internet. I cannot imagine the amount of energy that bounced off each other when you were all finally in a room together and you realize, I'm not alone. Look how many of us there are. And I am so jealous of that moment.
And it was the usual, we were all taking care of underserved communities. So when we got together with meetings like that, we'd hear, oh, they're doing that over there. We can do that. We can do even more of that. And they would expand this and whatnot. And it was just delightful. And that's really, I have to say, would put me on a pathway for the rest of my academic career, even though I gave a lot of talks about geriatrics and the value of home visits and hospice care and end-of-life care. I would almost always add, or mainly put it into the context of language differences. And my titles of my talks usually would have the word language barriers crossed out and the word differences. And I would make the case, you know, what if Ileana was one of my patients? And I said, well, there's a gender barrier there, so, you know, I couldn't do such a good job. No, it's not a barrier. It's not a religious barrier, a gender barrier, a class barrier, a color barrier. No, us healthcare providers, especially us doctors, are trained to do the best we possibly can for everybody who's different from what we are, period. Calling it a barrier is like making an excuse, history unobtainable, secondary to language barrier. Get rid of that. They're just differences. And there's actually some good things about differences. They're not just barriers. So when I heard about the SOMI, the Seattle Organization of Medical Interpreters, I was amazed. Wow, they were there even before we had an organization in Boston. And we kind of were like, okay, collaborating, competing to see who could get better and better and better. And I believe that these national and international meetings started with a working group that originated, in my recollection, from Robert Putsch and the Seattle Organization for Cross-Cultural Healthcare and the Seattle Organization of Medical Interpreters. And for several years, even though the MMIA was the only, there wasn't anything that claimed to be a national organization. It was the Massachusetts Medical Interpreters Association, which later went on to skip national and become international. But I got to go to all of these meetings of the working group. And again, I could just give them the point of view of a healthcare provider who only spoke one language and needed. And again, over the years, I realized these people were not just tools like CAT scans and blood tests that we needed. Gee, they were actually individuals. They were people like the other people that we needed sometimes as tools, the social workers and the physical therapists and the nurses. And that we needed to link up with them. They needed to become part of our team. We needed to know who they were, where they were trained, where they came from, what they knew about their community, this patient, et cetera. And then we'd share a little bit about ourselves and what we cared about, what we were trying to figure out with this new patient or family, et cetera, et cetera. And it just became, for me, more and more fun. It was the most rewarding thing I've done in my entire career. It was new patients with a language I didn't know, maybe a culture I didn't know, but with an interpreter with initials after usually still her name. And now, just like if it was an RN, PT, or MSW, I knew who they were. I knew what they knew. I knew how they were trained. I could trust them. And then, bang, they were immediately a member of the team. So I was a founding member of the National Board for Certification of Medical Interpreters. I loved the idea. I mean, quite frankly, I was there when training for interpreters first started occurring, including some work that I did on my own. But there was nothing formal about it. There was no professional organizations doing training for interpreters in the very beginning. And then I was around as these organizations became organized, professional. They were vetted by accrediting organizations who would look at a training program and say, okay, you're doing it right. You meet our criteria. You're accredited. And then I was around when the accredited training organizations could produce eligibility for certification, just like every other member of our healthcare team was required. It was not just a good idea to be certified as a doctor. In order to practice, you had to have it, training and certification. And then finally, and I'll throw this out as the next step for the profession, hopefully not too much longer. When I moved from New York City to Boston, I realized I had to be vetted by the state, that my license didn't count, and that they wanted to know more than just my training, my certification. They needed to know what laws I might have broken, what fraud or abuse I might have been involved with, and to make sure that I was a candidate for a state license to practice medicine as a healthcare worker with the state law. And it's a matter of time before, I mean, I have seen interpreters who violated some of our principles, of ethics and whatnot. I remember most famously a guy who was working the OBGYN prenatal clinic, and he would, quote, interpret for the doc while the doc was in the room. And when the doctor left, he would try to talk the woman into not having an abortion because they were sinful and immoral and whatnot. And after a few episodes like that, we realized that that person was violating what was an emerging code of ethics. And even though they were good at 2 languages and new medical terminology, they were not appropriate to be a professional interpreter, and they were let go. And that's why I think state licensing with occasional updates will be part of the future of medical professionals called interpreters. And yeah, they can be annoying. Fees, training requirements, all sorts of stuff. But everybody else in that room with the door closed, taking care of that patient, is required to go through that updated training, pay a fee, take a test, or whatever, qualify for renewal of your license. And professional interpreters should look ahead. The one good thing about licensing, I think it's the main thing that will bump the pay grade of professional interpreters. Once they're licensed and even unionized, like I was for 10 years as a doctor in New York City, will make the case that our interpreters are professionals, just like other members of the healthcare team, licensed, compensated, appropriate retirement, healthcare packages required for their employment, just like all the rest of us. So that's where I am. And I have to say, I have been mostly watching what this profession has done. I just watched Raquel, followed her around, and just said, wow, to every meeting I got to go to, and then took some information from that, brought it back to the hospital or the clinic to the people I worked with, and let them know. And it was sort of a cultural, medical to other cultures interpreter when there weren't too many. I'd look around every once in a while at the meeting. I would ask for raise of hand any other doctors who were there. And in the very beginning, other than if I was in Seattle, Bob Putsch would be there. But now there are plenty. And I will say, wherever you are in the country, wherever you work for, find that person whether it's a doctor or a nurse or somebody at a high level who will partner with your profession in that institution to advocate and insist that in order for us to be satisfied, to be accurate, not be sued, not waste money, and to have people who trust us and come back to see us in our clinic, we need you. And period. I always acted as though I knew nothing about immigrants. That wasn't a big deal. I never mentioned Nana. That it was about the profession that I practiced and how critical it was to have professional trained interpreters in order to do my work. And yeah, that was nice for immigrant communities. But if you focused on that in these medical, high level administrative sessions, there was a little, oh yeah, it's political. No. When you focused on wasted money, malpractice cases, mistakes and whatnot, now all of a sudden the ears opened and they would listen to a doc or a nurse or somebody else.
We all need someone like you at the table to help us with our arguments, because
Yes.
This is the way the world works. And when the doctor says, I need the interpreter to do my job, just like I need an x-ray machine to take an x-ray, and I know that they're expensive, but that's what I need. It's totally different than all the heartstring pulling stories and anecdotal evidence that we can present, because that's not how decisions are made. So thank you so much for being at the table for so long and being so strong in your arguments to support language.
Remember, my job was just taking care of patients, being a clinician. I get credit for doing research. I was not a professional researcher. When Raquel and I came up with an idea of some data that we needed to leverage our advocacy points, then I would find some real researchers and suggest, gee, here's an interesting question you could answer by doing a research project like this. And they would say, wow, that's a great idea. Let's see if we can get some grant funding for it. And then I would wind up, when it got published, as one of the middle authors, because I didn't need to be first or last. But that's that's what convinced the American Medical Association, the American College of Physicians, and all the other national organizations, was the research data that showed that professional interpreters were better, different than ad hoc interpreters, in the same way that a CAT scan was better than what we used to call a brain scan in the old days. You got it right with the professionals, and that's why it was required. And it shouldn't be hard for you young people, not to stereotype all of you, to find somebody better than me, somebody who I just want to make sure these old stories of the horrors that we used to consider normal are not forgotten. As I've said, in order to steer our pathway forward, we need to be able to take a peek behind and see where we're coming from. And that'll help us pave the way, as they say.
Absolutely.
All right. And you can see I talk too much, but getting a doc who talks too much is not such a bad idea.
Thank you so much, Eric.
Well, thanks for really an honor of being part of the organization and being able to talk and reach out to anyone who's willing to listen to me for 10 minutes. And thank you, seriously. I appreciate it.
Bye, y'all.